Hi, my name is Fay Kastrinos, and I will be speaking today on genetic risk assessment and screening for pancreatic cancer. I'd like to thank Immunovia for sponsoring today's webinar and the CGA for their continued commitment to education and research. A few disclosures here. Research funding is from Immunovia Ambry Janssen, as well as a consultant for Immunovia Ambry, and I serve on a DSMB for interactive scopes. So the outline for today, why the need to identify individuals at high risk for pancreatic cancer. We're going to talk briefly about germline pathogenic variants associated with increased pancreatic cancer risk, highlight some other high risk groups, and then to also highlight the genetic testing is a risk stratification tool. So why is there a need to identify high-risk individuals? As we all know, pancreatic cancer is deadly. It's the third leading cause of cancer death in the United States, and it will be rising to the second leading cause by 2030. Only 10% of individuals undergo potentially curative surgery, and the 5-year survival across all stages is approximately 9%. So our means to improve mortality related to pancreatic cancer really relies on the detection and surgical resection of cancers that are diagnosed at the earliest stage or precursor lesions that have high-grade dysplasia. So a big question is, do we really screen the general population? And a lot of that depends on the screening test, the performance of screening tests, including the sensitivity and the specificity of those tests, but also the positive predictive value, where this is the probability that individuals with a positive test truly have the disease. And a lot of the positive predictive value depends on the prevalence of disease in the population. So just an example here, if we have a good screening test with sensitivity and specificity as shown here, with a high prevalence in a population, let's say 50%, we see that the positive predictive value is very high, and it trickles down as the prevalence of disease in the population decreases. So if we were to diagnose 20 individuals with pancreatic cancer amongst 100,000 asymptomatic individuals being screened, if we applied a biomarker with great sensitivity and specificity, we would have a positive predictive value that is low at 1.2%, and it would really be picking up some false positive results. So we really are focused on enriching and highlighting those populations that would justify screening. So we select populations with increased prevalence of pancreatic cancer, and these are our high-risk individuals who have a family history of pancreatic cancer or germline mutations associated with pancreatic cancer, precursor lesions related to the pancreas, and another population that is currently under study are those with new onset diabetes, which is not something we're going to talk about in this webinar today. So individuals with family history of pancreatic cancer, we know that approximately 10% of all newly diagnosed individuals with pancreatic cancer report a family history of pancreatic cancer, a portion of which have a genetic predisposition with a known pathogenic variant in the family, and a larger percent that has familial aggregation with multiple relatives with pancreatic cancer. And here we see a study, an old study, which really looked at the burden of pancreatic cancer amongst first-degree relatives, and then the associated increased risk and incidence of pancreatic cancer. And here I just want to highlight, with an increasing number of first-degree relatives affected with pancreatic cancer, we see how high the incidence ratio goes and how the number of individuals affected by pancreatic cancer increases. And this is where the data really comes from in defining a familial pancreatic cancer kindred, which is a family where there are at least 2 or more individuals with a history of pancreatic cancer, and that at least 2 of the individuals have a close degree relationship, a first degree relationship to each other. So a parent-child relationship, a parent-sibling relationship. And here is a pedigree to highlight and define a familial pancreatic cancer kindred. 2 individuals in close relation to each other, and this is an individual who comes in to see us. This family would be identified as a familial pancreatic cancer kindred, and there are a number of implications for this individual who presents to see us. One, this individual will be eligible for pancreatic cancer screening and also eligible for germline testing for inherited cancer susceptibility genes associated with pancreatic cancer. And the importance of that, if we were to find someone who is positive, are the implications for additional cancer screening and preventive strategies for this newly identified individual with a pathogenic variant, but also for cascade testing for individuals who too would be at risk of carrying this familial variant. So what are the results if we were to take individuals from a familial pancreatic cancer kindred and check for germline pathogenic variants? What would we find? So in this study, 185 individuals with pancreatic cancer who were from FPC families underwent multi-gene panel testing, and 14% were found to carry a pathogenic variant, and these are the deleterious mutations that were detected. You could see them here with the frequencies increased in BRCA2 and ATM, amongst others. And then the more you look, the more you find there are additional susceptibility genes associated with cancer, some of which don't have a clear relation or quantifiable risk yet. But with more multi-gene panel testing done, the more we find. I want to highlight another study, the very elegant study, large number of pancreatic cancer cases, a case control study, which actually was not on a selected population of individuals with pancreatic cancer. So these were all comers newly diagnosed with pancreatic cancer presenting to the Mayo Clinic over this time period, and their controls were coming from two large databases where germline genetic testing were available and served as the control group, and 21 candidate genes were tested for. Now, the prevalence of mutations in these unselected PDAC cases was 8.2%, and there were 6 genes that were significantly associated with pancreatic cancer. And the prevalence of mutations, if you isolate it to these 6 genes, was 5.5 in those all comers with pancreatic cancer. And if you further stratified the group based on family history, you saw an increase in the prevalence of these 6 gene mutations. And here are the 6 genes that were shown to have a statistically significant difference in odds ratio and cancer risk amongst those pancreatic cancer cases and controls. And we see the highest risk being in CDKN2A, and then subsequently a lower risk, as you see here, with the genes shown here. And these were statistically significant. A little bit of a surprise that PALB2 wasn't on the list, but there were few cases, and one could make the argument perhaps that it was trending in significance. I want to highlight here, and this group very well knows that if this patient were to be coming in for genetic evaluation, we would see that the mom is alive with a diagnosis of pancreatic cancer, and we would definitely recommend that she undergo germline testing. I want to pause though to highlight 2 important things: that if this patient is presenting for genetic evaluation and is offered genetic testing and found to be negative, that we shouldn't just stop there, because her child is eligible for a pancreatic cancer screening, even though a germline pathogenic variant hasn't been identified in the family. So I do want to highlight that, that we shouldn't forget that eligibility criteria for screening does depend on clinical criteria being met by burden of pancreatic cancer in the family. So that if an oncologist were doing the germline testing for point of care for the implications of treatment, that we wouldn't just stop at this individual, but would want to counsel this patient on pancreatic cancer screening and prevention. And I want to highlight the NCCN guidelines now that recommend pancreatic cancer universal germline testing for all individuals with pancreatic cancer. Again, for treatment implications, and multi-gene panel testing is indicated here, but also that first-degree relatives are eligible for pancreatic cancer. So if a patient presents and a family member is deceased with pancreatic cancer, that they too would be eligible for germline testing, with the potential subsequently for screening for pancreatic cancer if found to carry a pathogenic variant. These are the affected genes with which there is an association with pancreatic cancer. And I have to say that the associated cancer risks, that these are numbers presented here from a couple of studies, but this is still a moving target as more multi-gene panel testing results come out, that these numbers are changing over time. But these are the inherited cancer syndromes associated with an increased pancreatic cancer risk. And over here, I also want to highlight that hereditary pancreatitis is also carries a high risk of pancreatic cancer. The importance of quantifying cancer risk really was used to set the age of initiation for screening amongst mutation carriers, with those identified with the highest risk of 10% and higher undergoing screening at age 50. These guidelines here are of the CAPS consortia guidelines. So the multi-gene panel testing and yielding of results that are associated with these genes shown here, high risk of pancreatic cancer, would start at age 50 or 10 years younger than the youngest diagnosed, and they would require having a family history of pancreatic cancer. I have an asterisk here to show that there's an exception for CDKN2A, where a family history is not required, and that initiation of screening starts at age 40 because that very heightened risk of pancreatic cancer. With this genes and an estimated quantification of about 5%, the age, according to the CAPS consortia, was started at age 55 for the genes shown here, and again requiring that there is a first-degree relative or second-degree relative, but a family history of pancreatic cancer. I put an asterisk here because the NCCN guidelines in their recent iteration actually has made screening initiation at 50 across all germline mutation carriers. For hereditary pancreatitis, the genes shown here tested, and screening would begin at age 40 to 20 years younger than the first attack of pancreatitis, and in Peutz-Jeghers, those who carry an STK11 germline mutation, starting between age 30 and 35, and family history is not required for these genes. I want to say a little something about pancreatitis because they are a high-risk group, and that we should consider germline testing in individuals with pancreatitis who had childhood pancreatitis, recurrent acute pancreatitis of unknown cause, a history of chronic pancreatitis, particularly if diagnosed at young ages, or have a history of at least one relative with recurrent pancreatitis, chronic pancreatitis, or childhood pancreatitis. And multi-gene panel testing includes these germline alterations here, PRSS1 being the most penetrant of these germline alterations. And there are some limitations, and there is complexity in interpreting results, particularly of genes that are less penetrant. The presence of these latter three genes here alone, having these isolated pathogenic variants, is insufficient to cause pancreatitis. And we suspect that there are other risk factors and possibly modifying factors that contribute to the manifestation of pancreatitis and also to the severity of pancreatitis. The other issue also is that variants of uncertain significance are quite common. With respect to quantification of pancreatic cancer in hereditary pancreatitis, early studies were quite high in showing a pancreatic cancer risk of about 40%, and there was some overestimation due to the inclusion of smokers. When they took out smokers, the lifetime risk was about 20%, which is still very impressive and high. And the onset of chronic pancreatitis in these individuals is 20 to 30 years earlier than what we see in individuals with sporadic forms of chronic pancreatitis. At our center, we see a lot of pancreatitis, and especially with PRSS1 carriers. It's important for us to consider and start an early discussion in individuals who are severely affected about total pancreatectomy with autoislet transplantation. And that's important because there are other surgeries that we might want to hold at bay and minimize in order to preserve islet cell mass. especially in those who present again with severe manifestations and maybe going down the route of a total pancreatectomy. A modifiable risk factor, I want to point out something as simple as smoke cessation. Smoking has been associated with nearly 30% of all cases related to pancreatic cancer where they present at younger ages. It is dose dependent and results in accelerated tumor progression. And I want to highlight here that the pancreatic cancer risk in those with a family history among smokers and non-smokers is really impressive. So what are the strategies currently available for the early detection of high-risk individuals? The goal is to identify precursor lesions and targets for early detection. And the two paths in progression to pancreatic cancer that I want to highlight are related to the path and the Panin pathway, where we progressively go through the Panin path to pancreatic ductal adenocarcinoma, which is common. The other manner in developing adenocarcinoma is related to the IPMN and cyst pathway. So the success of a surveillance program is really to identify a resectable cancer, one that is at the earliest stage, the potential to detect and treat a Panin-3 lesion, which is on its way to developing pancreatic cancer, but is a precursor to adenocarcinoma, or this IPMN pathway with high-grade dysplasia. And currently, recommendations for screening really focus on imaging the pancreas in high-risk individuals through endoscopic ultrasound and MRI, MRCP. And here I show the advantages of early detection with respect to the sensitivity and specificity being high in endoscopic ultrasound, especially with good resolution for small lesions, the ability to perform fine needle aspiration of a cyst, for example, or of anything else that might be suspicious in the parenchyma, compared to MRI, MRCP, which provides good soft tissue contrast, doesn't expose the patient to sedation and invasive procedure. And a few of the disadvantages here, focusing predominantly that technical expertise is very important with endoscopic ultrasound, and that what we do right now is actually recommend that we could alternate between these two modalities in imaging. A cost-effective strategy to pancreatic cancer screen is seen with both endoscopic ultrasound and MRI, and the results of this study were really related to what the increased risk is related to PDAC, and if there was a five-fold relative risk that MRI was more favored, but the higher the risk, the higher the pancreatic cancer burden in families, that endoscopic ultrasound was more so performed. Again, if the test cost would increase for MRI, EUS would be most effective. And then there was a stop age that they also looked at, and 76 years was deemed to be a no longer screening favored for high-risk individuals. I want to report on one of the largest studies and long-term studies looking at the outcomes related to pancreatic cancer screening in high-risk individuals. These are results from the CAP study out of Johns Hopkins, a long-term study with 354 individuals who were deemed high risk, of which they were from kindreds, from familial pancreatic cancer kindreds. These individuals had different modalities of imaging, consistent imaging over time, and during different intervals, anywhere from 6 to 12 months earliest on, and would even be within 3 to 6 months if there were any abnormalities noted, particularly cysts, anything of high risk or abnormalities in the ducts or parenchyma. So a little bit about the results of this study. There were 24 individuals that were deemed to be progressors, meaning that they were diagnosed with pancreatic adenocarcinoma during the course of the study, or high-grade precursor lesions that warranted surgical intervention, as opposed to those that continued on the surveillance arm without any worrisome features found. Here we could see that the age of those individuals, the progressors versus the non-progressors, was somewhat higher, and so this was statistically significant. Again, the focus is that they're coming from familial that they have high familial risk and from familial pancreatic cancer kindreds, and a little bit on the features of what the high-risk features were on imaging that was statistically significant, dilated main pancreatic ducts, and multiple cysts. So worrisome features for the progression to pancreatic adenocarcinoma and high-risk lesions is cyst size that are large, thickened cyst walls, that with mural nodules in the cyst or within the main pancreatic duct. A large pancreatic duct, abrupt changes in the main pancreatic duct, and rapid growth over a short time frame during surveillance. Here I want to talk about a little bit about the outcomes and the survival time from diagnosis. The first group here, that's grouped here together, are those individuals with pancreatic adenocarcinoma who had surgery. The second group here are those that had high-grade precursor lesions that were treated surgically, and we see here that 100% of them were alive with surgical intervention. And the last group here that we see are those that had been detected with tumors outside of their surveillance interval, and we see the poorest outcomes here. So the detection rate for pancreatic cancer and high-grade lesions was around 7%. The cumulative incidence was 3.4 after screening initiation, and this is the most important take home, is that the 3-year survival rate was significantly higher at 57% for those high-risk individuals that were undergoing screening versus those who did not. And here is a visual in presenting those results, where we see here those individuals who had high-grade precursor lesions had the best overall survival, followed by those that were detected with PDAC during the surveillance interval, as opposed to those who fell out of surveillance and had worse outcomes. I want to talk briefly about a recent study that was published on endoscopic ultrasound outcomes in select carriers, those with these pathogenic variants. Most of the results of pancreatic cancer surveillance is heavy on including individuals with familial pancreatic cancer, from familial pancreatic cancer kindreds. So this study was really great in that it showed us outcomes specific to germline mutation carriers. Here, not uncommon to see these patients in our clinics because they've been diagnosed with breast cancer or have a strong family history of other malignancies and found to carry these mutations. So this group performed a retrospective analysis on these carriers who presented for endoscopic ultrasound and pancreatic cancer surveillance at a single institution. They focused on giving us and reporting outcomes on individuals, on carriers without a family history of pancreatic cancer. So I had highlighted earlier that for these mutation carriers, one of the criteria and eligibility to undergo screening was having a first or second degree relative with pancreatic cancer. So amongst 194 carriers, 64 of them, 33%, had no family history of pancreatic cancer. But in this cohort, they underwent an endoscopic ultrasound for surveillance. So predominantly women, BRCA2 carriers, 73%, only a small handful of ATM and PALB2 mutation carriers, and a majority of them had a personal history of some other cancer. The median age of having their first endoscopic ultrasound was 62. Approximately 2 EUSs were performed per patient, and a median of 3 years between the first and the last endoscopic ultrasound. So what were the results? It was not uncommon to find any abnormality in this cohort. 44% of individuals had something, the majority of which were cysts. So this is not uncommon even in the general population. There was a fraction of these individuals had parenchymal abnormalities, as noted here. I do want to focus in on the 2 that had pancreatic cancer. One of those individuals had a IPMN with high-grade dysplasia, who went to surgery and had a very small focus of adenocarcinoma in that surgical specimen. So this is a success of surveillance, and she is alive and well, has been reported. The other individual who presented with PDAC had fallen out of surveillance and presented after having had normal endoscopic ultrasound years later with an advanced pancreatic adenocarcinoma that was metastatic. I just want to highlight a little bit and talk about IPMNs. They are a precursor lesion that is very well visualized as opposed to the Pannin lesion, and they affect the main duct or side branches off of the main duct. And I want to highlight that they're not uncommon, that they're identified incidentally in about 15% of asymptomatic individuals that have had an abdominal MRI. And we categorize them into 3 types: those that affect the main pancreatic duct versus branch ducts, or those that have a combination of both. And amongst individuals that have proceeded on to have resections of IPMNs, we see high-grade dysplasia and the highest rates of high-grade dysplasia in pancreatic cancer amongst those that have main duct involvement or of the mixed type. But I do want to highlight that 24% of branch duct IPMNs have high-grade dysplasia and 17% with cancer, highlighting the experience and the study that I had shown to you that had focused on the EUS surveillance of those mutation carriers earlier, that the success really does hone in on selecting the right individuals to undergo surveillance. I do want to highlight here the importance of considering genetic testing in those with precursor lesions, because it might impact greatly how we survey them and the frequency with which to look. So current surveillance in anybody and all comers with IPMN really is based on the location of the lesion, the size, other features of the cysts. We have to be vigilant about ascertaining family history of pancreatic cancer or any other inherited cancer syndrome in these individuals that present with cysts, and consider genetic testing in those that have familial risk or suspected inherited cancer syndrome, because it really would change potentially their surveillance and making them more intensive surveillance of that cyst, as opposed to them not carrying a germline alteration. And obviously the importance of cascade testing for other cancer susceptibility and increased risk. So the challenges of a surveillance program, and we could use help and new tests to help guide us, or improvements on what we're already doing, is that pancreatic imaging cannot reliably grade dysplasia in the pancreas. Patients have years of normal testing. So how do we further stratify individuals, germline mutation carriers, who might be of lowest risk in these high-risk individuals? And is there something else that we can offer them with respect to screening? Many times follow-up of lesions that are benign and stable over time, particularly really small side branch IPMNs, which don't progress for years. Challenges are the incidental findings that then lead to additional workup for something picked up on radiology, for example, and continued subject participation. Patients are motivated for different reasons, and falling out of a surveillance program is a real issue. So in conclusion, enriched populations are important for us to identify because they are eligible for screening. And these high-risk individuals now, as we very well know, are those that carry germline alterations or have high burden of pancreatic cancer. Collaborative efforts are needed and continued, and further risk stratification is needed amongst those that we identify as high risk. We also are in desperate need of novel and validated strategies to screen for pancreatic cancer in these high-risk populations beyond what we have in imaging, and possibly complementary to what we provide now with imaging. And the use of genetic testing in families with pancreatic cancer is very much a valuable risk assessment tool. I wanted to thank everyone for joining us today. And I would like to introduce Dr. Thomas King, who would be speaking to us on the results, exciting results from the IMRE PanCan-D test. Thank you very much.
Thank you so much, Fay, for that excellent presentation. I'm Dr. Tom King. I'm Immunovia's medical director, and I'd like to tell you a little bit about where we are with our IMRE PanCan-D test for the early detection of pancreatic cancer. I've spoken about the test a few times at this meeting in the past. The test is now clinically available in our state-of-the-art laboratory in Marlborough, Massachusetts. I want to begin with just a very brief summary of the technology that underlies this serum biomarker assay. This is a multiplex assay that measures 8 serum protein biomarkers using our IMRE technology, which consists of single-chain variable fragment antibodies spotted on a slide in a microarray format. Patient serum is biotinylated and interrogated for the levels of these 8 proteins. And these numeric results are combined with the results of a commercial CA-19-9 assay to derive a decision value. The model that we build using over 1,000 samples then derives a decision value that is typically negative in individuals with pancreatic cancer and positive in individuals without pancreatic cancer. What I want to describe for you now is the pivotal study we used to validate the test in Marlborough and to achieve regulatory approval for our launch in August of this year. This is a large study that involved 167 PDAC samples, 56 of which were stage 1 and stage 2, as well as 203 familial and hereditary controls. These individual samples came from our PanFam clinical trial, which we are currently analyzing and hope to complete in Q1 of next year. These individuals are at high risk for pancreatic cancer because of known germline mutations or family history of pancreatic cancer. We also included healthy controls in this study. I want to thank all of our collaborators, both in Europe and the US, for their hard work in putting this study together. A little bit of detail about the demographics of patients. As you would expect, our PDAC samples came from individuals with a median age of 70 years old, with predominantly males. The PanFam cohort was about 10 years younger in age and predominantly female, and that corresponds to the composition of surveillance programs in the United States. About 28% of the PanFam subjects had prior cancers which were not active at the time of sample collection. This is probably not expected given the germline mutations that predispose to other cancers aside from pancreatic cancer. Our healthy controls were about 20 years younger than our PDAC samples. They were equally split between males and females, but they had a fairly wide ethnic diversity in the group, at least from the US contingent of the healthy controls. This slide also shows a summary of the types of cancer, predominantly breast cancer, that these patients had a history of. Also, I think it's important to highlight that these are not especially healthy individuals in the PanFam group. Collectively, these 200 or so individuals were taking more than 600 medications, some of them related to their prior cancers and others to various comorbid conditions. This blind validation assay was conducted in our laboratory in Marlborough using fully validated clinical testing, including a Cobas Roche analyzer for the measurement of CA-19-9. All of the microarray assays were performed under detailed standard operating procedures, and all of these procedures were validated. We use customized and validated software to analyze the microarrays and combine the results mathematically with those of CA-19-9 to derive decision values that were then transferred into our laboratory information system for analysis. And this is the results that we obtained. These are decision values plotted for the healthy controls and PanFam subjects in blue and green. And you can see that these form essentially a bell-shaped curve that has predominantly positive values. these samples tend to show a fairly tight distribution of decision values. And that's in contrast to the PDAC samples in red, which show a much wider distribution of decision values, strongly tending towards negative values. Importantly, this is a similar histogram that shows the results of the study that was used to develop the model that we use now for IMRAE-PanCan-D. This study was performed over a year before the study in Marlborough and was composed of completely independent samples. I think that the similarity of the results is rather striking and speaks to the reproducibility of this assay. Our results then correspond to a specificity of 98% in the PanFam group, which I think is quite good given the comorbidities and prior cancers in these individuals, with a sensitivity for early stage pancreatic cancer of 85%, slightly higher sensitivity for all stage pancreatic cancer of 87%. We were very happy with these results. Similar results were obtained with a healthy cohort with slightly higher specificity. Now, as I came to the point of really launching this test clinically and applying it in the United States, one thing that concerned me was genetic variation in the expression of CA19-9. As I think many of you know, CA19-9 is an oligosaccharide, and the terminal step in its formation is controlled by the Lewis antigen gene, which is a minor blood group antigen. The enzyme adds the final sugar moiety to form CA19-9. And deficiency in this enzyme from multiple germline mutations is relatively common in some ethnic groups. Literature would say that about 6% of Caucasian individuals have mutations in both genes that prevent them from forming CA19-9. But in African Americans, that figure is around 22%. I didn't want to launch a test that was going to have inferior performance in different ethnic groups. And the amount of information available about Lewis genetics is relatively limited. So we didn't really know what the pattern would be in other ethnic groups. Looking back at the literature, genotyped individuals who without cancer have different levels of expression of CA19-9 dependent on their genotype. In this case, LE is Lewis antigen gene. And if you look to the right of this figure, small e, LE corresponds to defects in both copies of the gene and corresponds to very low levels of expression of CA19-9. Based on this, it made sense to exclude individuals with very low CA19-9 values from analysis in our study and in the clinical practice of the assay, with a hypothesis that these individuals are likely genetically deficient in the ability to form CA19-9. When I did this, we removed about 10% of individuals from the blind validation study in total, 55 subjects, and we increased our sensitivity for stage 1 and 2 cancer from 85% to 89%, and from all stage pancreatic cancer from 87% to 92%. I think really excellent performance characteristics. What we excluded were about 13% of healthy individuals, and most of these came from the United States, which had a much more ethnically diverse cohort. And when we looked at the ethnicity of individual samples, this correlates fairly well with the reports from the literature. But we also found that different groups that had not been previously reported in the literature also had significant fractions of individuals who were deficient in the ability to form CA19-9. I also thought it was important to look at our assay at the individuals who had very low levels of CA19-9 and determine whether or not the IMRAE portion of the assay, that is the other 8 serum protein biomarkers, were capable of distinguishing those with cancer from those without. And that shows the results of this analysis. The ROC curve is choppy because only 55 individuals are included. but it shows significant discrimination between individuals with cancer and those without cancer. And that gives us, I think, a real hope that we may be able to design a modified model that will be predictive in these individuals. And that's something that we are very interested in for the future. I wanted to finish by saying that I think that the framework for evaluating patients at risk for pancreatic cancer is really starting to change. I think a more precise understanding of the interaction of specific germline mutations with potentially modifiable risk factors such as smoking and obesity are going to allow a more precise evaluation of risk. Also, I think what we need to do over the next few years is learn how to integrate the results of PDAC biomarkers such as IMRAY-PanCan-D with specific pathogenic germline mutations that predispose to cancer, and understand how those work together and how we can best use this information to guide the management of patients. Also, I think it's going to be important to look at genetic variation that controls the expression of biomarkers such as CA19-9. I think there's the potential, particularly with IMRAY-PanCan-D, to even improve its sensitivity and specificity further by adding that genetic information to the results of the biomarker test. Also, clinicians have to decide how to and learn how to integrate biomarker findings with pancreatic imaging results from EUS and from MRI. This, I think, will take time, and we hope that over the next few years, this process will move forward. Also, I think there's real interest in evaluating genetic variation in genes that modulate inflammation in the pancreas. Clearly, pancreatitis is a significant risk factor for PDAC, and I think looking at the genetic background, seeing how that interacts with environmental risk factors is also going to be important in really fine-tuning risk assessments for these patients going forward. We thank you all for coming today, and Dr. Kastrinos and I would now be happy to take your questions. Thank you all so much for attending today. It's been a pleasure to talk to you. And again, thank you, Fay, for speaking. It was really an excellent review of risk factors for pancreatic cancer. If you want to type in your questions, we're happy to address them. There are just a couple here now. One is a question, is IMRAY-PanCan-D available in all 50 states? And I can answer that. Currently, we're available in 45 states that do not require individual state licensure. So unfortunately, right now, New York and California, Pennsylvania, Maryland, and Rhode Island are excluded for us. We just received our Massachusetts licensure in August of this year. And with College of American Pathologists accreditation and other things, it takes about 6 months to a year to work through these additional licensure requirements. But we expect that to be done fairly early in 2022. Another question, is your IMRAY data published? And no, it is not as yet. We've submitted the blind validation that I've described for you today for publication, and we're waiting to hear from reviewers. I think that's really a very important step for us to complete so that all of this information can be out there for thorough evaluation. Fay, perhaps I could ask you, once you start to use biomarker tests in conjunction with imaging studies, how do you think you might use it? I know that that's a tough question to start off, but I thought I would pose it to you.
You know, I pointed it out in the talk. I do have a population, the younger patients that present for screening, who we have many, many years of negative imaging tests, and we really want them to continue on with surveillance. So I don't want them to have a false sense of they don't need to do anything, or they can space it out on their own and not show up. So I could see integrating a biomarker between imaging tests. I think we're going to need to have studies to see at what frequency we could do that, where we can alternate potentially between imaging and adding in a biomarker, and using it potentially to stratify those that might be of lower risk, and you know, maybe fine tune the initiation of surveillance. Maybe 50 years is a little too young for some patients, so maybe it can help us, you know, personalize that approach somewhat. But I do see it being used and incorporated with imaging, and you know, I look forward to offering patients something that's non-invasive. I think we're going to need a lot of collaborative work to see if we can stretch out the imaging as well, particularly in those that have had negative tests, negative imaging for a while.
Yeah, I think particularly as you highlighted, there can be a lot of dropout in terms of participation in surveillance programs. And actually, I saw a recently published article that indicated only about 21% of at-risk individuals are actually enrolled in surveillance programs. So the ease of testing and availability of testing, say with a blood test compared to imaging, I think is significant.
Yeah, absolutely. And with COVID, we had patients that weren't able to undergo surveillance because there were no active issues. So even our high-risk patients, we had to work a little harder for them to get screened. So it would be a great option.
Okay. And Fay, here's a question for you. How would you determine risk in a mutation-negative patient with a paternal first degree and a maternal first degree relative with pancreatic cancer?
Was there a question also, is there being an ATM mutation?
Yeah.
I'm not so sure.
On the maternal side, I guess, yeah. Sorry, I'm still decoding.
No, it's okay. It's okay. Well, if there is a known familial mutation in ATM and that patient doesn't have it, you could potentially, you know, mitigate the maternal degree of risk because that patient hasn't inherited that ATM mutation. There was recent inclusion of both a parent having both parents with pancreatic cancer in the CAPS consortium, and we really don't have good data on that, taking into account both sides of the family. So I really do focus in on the number by familial side. In this case, if you're saying ATM was there on the maternal side and then this patient didn't inherit it, I would weigh out more the paternal side. Hope that helps. I'm happy to, you know, if you want to email me directly, we can talk about more details related to the family.
Okay, thank you. A question, given the operating characteristics of PanCan-D with 92% sensitivity, do you think it will be helpful in the early detection of pancreatic cancer, even in an enriched cohort? And, you know, I think that's something that time will determine. Certainly the sensitivity of the assay and its specificity are substantially better than what's been available from a biomarker. And, you know, I think clearly the imaging studies, while they're useful, they can be ambiguous and difficult to resolve differences between different interpreters. So I think there's really a very strong potential that this will be impactful. Also, the fact that it is a blood test and is easily administered, I think will help in terms of the dissemination of screening to individuals who may not want to participate in surveillance programs or who are geographically distant from surveillance programs.
I have a question, Tom.
Mm-hmm.
If I can right now. A population now, an enriched population in which screening is considered and under research protocols right now is those with new onset diabetes, which is much more prevalent than our, you know, mutation carriers, our patients with pathogenic variants in family history, just by numbers in the US population. Do you have any studies, ongoing studies or proposals that would include the performance of IMRAE PanCan-D in new onset diabetes?
Well, at this point, we have really limited information about test performance in diabetics, but not necessarily new onset diabetics. Our PanDIA study, which hopefully will initiate soon, will look at a large cohort of Swedish new onset diabetics after age 50. So we hope to be able to address that question soon, but we have not addressed it as yet.
It would just be much more cost effective than, subjecting to imaging, and at least it would be great to have that data.
Absolutely. And, we have been really active with Pri-Med and primary care physicians in trying to provide some education around the risk of cancer in new onset diabetics. And what we pretty much invariably find is this is a real surprise to doctors. They really are not aware of it. And I think it's important just to get that information out there to get people thinking about it and hopefully start to lobby for some action in terms of really evaluating these individuals more carefully. A question, can you speak to the use of GRAIL test in screening? Oh, GRAIL is really a rather different assay than IMMray PanCan-d. IMMray PanCan-d is a protein biomarker assay that is really designed for one disease. GRAIL is a liquid biopsy that looks at DNA methylation predominantly and screens for many different types of cancer. The sensitivity, at least that we've seen published for GRAIL for pancreatic cancer, is substantially less than the IMMray assay, probably around 60%, we think, although the amount of information that's out there is a little more limited at this point. So given the substantially lower sensitivity of the assay, I think it would not be such a good choice in individuals in a pancreatic cancer screening program. Some questions about the cost of IMMray PanCan-d and insurance coverage. We are actively working for insurance coverage. When a new test is launched, you're pretty much never in the position to have insurance coverage from the get-go. So that's probably going to take us at least another 9 months to get to that. Currently, the test is offered as a self-pay, and the base price is $995 with various self-pay discounts that lower the price by 25%. We also, I think as most companies do, now offer financial assistance to individuals who have less ability to pay. And I would say thus far since our launch, we've not refused to do the test on anyone. So we really work very hard with our customer support team to support patients or individuals at risk. Let's see, I think that is all of the questions, unless someone else has any. Fay, did you have any other questions for me?
No, I don't. I saw one more that popped in. I think it's directed to me, Tom. If a person has a mutation and a family history of pancreatic cancer, should we assume the person with pancreatic cancer had the mutation in the lineage of the mutation? That's a good question. I often will recommend many family members be tested to determine which side of the family the mutation is coming in, but I do offer screening to those individuals who are who carry the pathogenic variant, and I do use that family history of pancreatic cancer for eligibility purposes to screen them, if that helps. But yes, that's the only other one I see, Tom.
Okay. Well, Fay, again, thank you so much for your wonderful talk today, and thank you all for attending today.
And thank you, Tom. That was great to hear the new results. Thank you.